Hello, everyone. Welcome. Good afternoon on this fine Thursday. Before we jump into our webinar today, we do have a set of polling questions for you to kick us off. So I'm going to go ahead and launch the first polling question. So that should pop up on your screen now. Go ahead and answer which one best describes you. Ten more seconds to get your vote in. All right, we're closing this one now. And the next question. Five more seconds. Seeing about 80% from urban and about 20% from rural. So we're going to close that. Next one. Five more seconds. All right, last question here for you. This question is really speaking to homelessness support. So go ahead and get your vote in, especially on this one, since we're really looking to speak to this issue today. And closing in 5 seconds. Noting that more than 60% of you have supported someone who is homeless, with another about 15% either being homeless themselves. So high representation on the webinar today. So we're going to go ahead and get started. So if you're here to listen today about a webinar on housing, homelessness, safer supply, and pandemic prescribing, you are indeed in the right place. Before we get started today, though, just taking a moment to really reflect on the lens in which we're gathering and listening in on this webinar on behalf of my colleagues from the Lower Mainland, we would like to respectfully acknowledge that the land on which we're working is the traditional territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. But just taking a moment, this is a provincial webinar. We're reaching folks from across our province. And so wherever you are, wherever you're at, taking a moment to think about the lands on which you're on, and expressing that gratitude however you think is best. But for me personally, just thinking about how lucky we are to live in British Columbia on such beautiful territories. So here's our agenda today. So we're going to do just a very brief welcome and an introduction of our amazing panelists today. We have some prescriber remarks right at the beginning to speak to risk mitigation guidance. We're going to see some evidence-based recommendations for homelessness as it relates to safer supply. we have a really exciting discussion period for that'll pertain to some specific experiences around Oppenheimer Park, but then also the experience of being homeless and its effects on people. So that'll be a really fruitful discussion. And then, as always with our webinar series, there will be time for your questions and discussion. So on your panel, you should be able to see a little chat function. You can ask any of your questions in there, and we're going to circle back to them at the end and hopefully have lots of time to get through some of those. So let's move into our panel. So as I said, a really, really great panel for you today. We have Dr. Sharon Vipler, who's the Program Medical Director and Regional Department Head of Addiction Medicine and Substance Use Services at Fraser Health. She's ABAM certified and clinically works at the Creekside Withdrawal Management Center, Quibble Creek Oak Clinic, and with the St. Paul's Addiction Medicine Consult team. And so she's going to be providing that prescriber perspective for you today. Then we have Dr. Bernie Pauly, who's a registered nurse and professor of nursing at the University of Victoria and a scientist at the Canadian Institute for Health Research. Her program of research focuses on substance use harm reduction and the social determinants of health with a specific focus on housing and homelessness. She is the nominated lead of the Canadian Managed Alcohol Program Study and the BC Community Collaborative Substance Use Laboratory. For our discussion period, we have two great speakers today. So we have Patrick, who is a career activist and project manager whose work focuses on community building by an equity and social justice lens. Throughout a long career in supporting individuals experiencing homelessness, poverty, and addictions, he has opened and managed a wide spectrum of social supports, including shelters, transitional and social housing, overdose prevention sites, clinics, supportive recovery homes. He's working with the PHS Community Services Society and has also walked beside special communities in homeless encampment protests in Victoria, Nanaimo, and Vancouver. Last but certainly not least, we have Guy Felicella, who's a passionate advocate for the vulnerable people who suffer in addiction. He spent nearly his entire life suffering from the same disease, and now he educates communities on harm reduction through public speaking to eliminate the stigma that exists around it. Mr. Felicella is a peer clinical advisor with the BC Centre on Substance Use and has started a career with VCH and the Ministry of Mental Health and Addictions, in addition to doing various talks around school districts to educate students on addiction. So with that, I'm going to pass it over to Dr. Sharon Vipler, who's just going to walk us through the risk mitigation guidance on a high level and a little bit about the prescriber perspective. Take it away, Sharon.
Thanks, Amanda, and thanks for having me be a part of this. In preparation for today, I was reflecting on my education journey in medical school, and you know, in medicine, when I was training, you were taught this is the problem, this is how you fix it, and then we had maybe one class where we looked at the social determinants of health, and we all dutifully memorized that list, but there wasn't a lot of focus put on. So what about, like, what happens when you mix that, like, problem solution with the social determinants of health? And so I really, really do appreciate the opportunity to be engaged in these kind of webinars, because not all the solutions that we're taught fit every patient population. So without further ado, let's chat a bit about the background to why we're having the conversation specifically today. As most of you are aware, March 11th, the World Health Organization declared the COVID-19 pandemic, and on the 17th, so not shortly thereafter, BC declared a public health emergency. We became very aware that physical distancing measures may have meant there would be reduced hours of operation for pharmacies and clinical services, and that perhaps these services would not be able to meet the needs of patients because of that. There was also concern, legitimate concern, that there may have been disruption to the street drug supply. And so with that, there has been an aim to employ strategies to ensure safe access to substances to reduce the risk of harms and death that can be associated with either destabilization or the experience of withdrawal.
Oh, Sharon, I think we lost.
Oh, can you guys hear me now?
Yep, loud and clear.
Okay, next slide. Great. So I imagine that there are those of you on the call that are aware, but for those of you who haven't come across this, this is a document entitled Risk Mitigation in the Context of Dual Public Health Emergencies. And really there's no guessing what it covers because that title is pretty self-explanatory. But really what it is a guidance manual or guidance document that can help individuals, prescribers, help patients manage withdrawal, cravings, and other forms of harm from substances, opioids, stimulants, illicit benzodiazepines, tobacco, and alcohol. And really the goal is to support patients to self-isolate or maintain physical distance and avoid any kind of substance-related harm. It is really important to recognize that this is not a treatment guideline. Rather, this is guidance that can be referred to when, our pre-existing guidelines can no longer provide the care to the degree that we need to provide. Next slide. So who's eligible for the guidance that's covered in that document? So first off, these are individuals that are at risk of COVID-19 infection. And if your first thought is, well, that's everyone, you would be right. And that there was a degree of intentionality in providing a bit of a broad criteria to allow for those prescriber patient evaluations to occur on a case-by-case basis. Of course, it's very obvious that this would be to, patients that are confirmed COVID positive would be eligible, and that even suspected cases. So, we often will refer to these individuals as swab pending cases or people that find themselves in a situation of having to be self-isolating. There should be a history of ongoing active substance use. So there should be a defined history or collateral history that shows that individuals have been using opioid stimulants, alcohol, benzos, tobacco as examples. And these should be individuals that are at risk of high risk, of withdrawal, overdose, craving, or other defined harms related to drug use. I will draw your attention that within that eligibility criteria, there's nothing that says that we can't use this criteria to include pregnant patients or youth. So there's no age elimination. There's nothing that says that we can't consider these criteria for pregnant patients. Moving along, looking at more specific elements of the document, with regards to opioids, it does talk about opioid agonist therapy and perhaps looking at increasing patients' doses or increasing carries outside of the usual guidelines, looking at providing oral hydromorphone, usually in 8 milligram doses, up to 14 tablets, or looking at MS-LON. So that's the 12-hour formulation of the slow release or long-acting morphine. Benzodiazepines are probably the one area that we have kind of proceeded with the most caution. And that's really because it's very difficult to know what the quality and variable purity is with regards to the street supply of benzodiazepines. Moving on to stimulants, this is an area that actually has been studied in terms of treatment of stimulant use disorder, and many people draw attention to the fact that there's no good evidence to support treatment of stimulant use disorder with stimulant prescribing. But I will draw attention to the fact that this is not a document that's looking at treatment. This is a document that's looking at prescribing practices that will help people isolate. And so looking at perhaps using dexedrine or Ritalin, either slow release or either sustained release, or immediate release formulations to help with that focus or goal. And then two substances that I think have a lot more comfort with, alcohol and tobacco. So nicotine replacement therapy is widely known and widely used, but ensuring that our patients have access to it and helping facilitate that. In some jurisdictions, it actually looks as simple as providing access to cigarettes, but in most jurisdictions, it's the nicotine replacement therapy that we're more familiar with. treatment for alcohol use disorder, so really looking at relapse prevention opportunities, but then also recognizing that we may need to engage in approaches to acute alcohol withdrawal. And there is a separate document available on the BCCSU site that really does a good job of outlining how to approach that. And then, of course, there's always managed alcohol programs, which I won't say much more about because it's a little bit daunting being on the same call as one of Canada's leading researchers on that topic. So we'll leave that to Bernie if the opportunity arises.
Yeah, that's a perfect transition. So with that, we're gonna move over to Dr. Bernie Pauly, who's gonna walk us through some recommendations specifically as it pertains to homelessness and the pandemic. Over to you, Bernie.
Thanks. That was a great introduction. Where I want to start with the evidence is talking about what is one of the best documented evidence-based interventions that there is for homelessness, and that's housing first. Canada conducted the at-home shave swab project, which was the largest in the world, and it showed conclusively that it works for even people who have been homeless for a long time. And that's really fits into this discussion because it's predicated on the understanding that people have a right to housing. They don't have to be sober or go through treatment or, be on a continuum in order to access housing, but rather the understanding that housing itself will help people to stabilize and move forward. But it doesn't mean dumping people into housing. And I think that's a really important when we're talking about safe supply, because in housing first, it's housing plus supports, and the supports that are deemed appropriate and important for that individual. So, given that we now have the risk mitigation guideline, it's a really important way forward because it provides a really low barrier alternative for people that may actually be one of the most important supports that are part of a housing first kind of approach. We often talk about housing first as a set of principles as opposed to necessarily a place. And there are examples. I mean, clearly the best intervention is permanent housing for people to stabilize. But we can talk about applying housing first principles in other kinds of settings as well. And I do not in any way want to leave the impression that, safe supply should only be provided to people if they are moving into housing or some other kinds of more stable housing arrangements. The relationship between substance use and homelessness is quite complex. And, people can often find places of stability living in an encampment. They can find it, living in other kinds of settings, and safe supply could be a really important part of that kind of support and stabilization. And so if we think of the housing first principles, one of the core principles, there are several, and you can certainly, they're well written up in the Canadian Housing First Toolkit, but one of the most important principles, at least to me, and it's one I talk about a lot, is that harm reduction is a core principle of housing first. And it goes to what I said before, is that people can be provided with immediate access to housing without requirements of housing readiness like sobriety, and safe supply would be an important support as part of that. And I think as housing providers or people who are supporting people that are homeless, it would be really valuable, to advocate and support them to get on safe supply, because I think one thing I've learned, and I'm guessing others might talk about this a bit more, is that it's really hard sometimes to have those conversations with a physician, because you have to talk about substance use. people may not feel safe to do that. And so being, a good support, a good ally can really mean helping them to have those conversations and be supported if that's what they need. It can also be, kind of raising the idea. And then I think if someone is on safe supply, making sure the supports are in place, whether that's, wellness checks, or it's making sure that they're connected with the right pharmacy and have the delivery, like, the mechanics of making that happen. I think housing and shelter providers can play a really important role that can help people to stabilize, because we consistently see in the literature that when people can stay in one place, they can start to stabilize and they can start on a path to recovery. And I don't mean by that a path to abstinence. I mean a path to finding a sense of quality of life and stability that works for them. And harm reduction is a core part of that. So this slide is really, in a nutshell, summarizing up a lot of the evidence-based interventions that we have that housing and shelter providers can use when they are, integrating harm reduction in whatever setting they're doing it. And I think it's important to include, because I think we're introducing into housing and shelters and other settings safe supply that's a wonderful complement to potentially other harm reduction interventions that are already in place or may be available somewhere in the community, or may not be. So we have to think about that. But if you sort of think about those interventions in three big categories. One is, interventions that support safer use. So you can see probably many interventions you already have: harm reduction supplies, naloxone, safer use education for both illicit drugs and alcohol, drug checking services. And I realize, there's a limited availability of those, but they are still a harm reduction intervention. Second category, safer spaces. So having a space or having like an OPS obviously has to be aligned with physical distancing guidelines, or introducing peer witnessing, and then the inhalation space. And those things still remain very important as evidence-based harm reduction interventions that complement the third one, and of safer supply. And I realize I've used that term a bit broadly, but I actually had this slide done a long time ago, where before we had the risk mitigation guidelines and the types of pharmacological interventions like OST, and then now complemented with the risk mitigation guidelines, and also managed alcohol as well. So underpinning all of that, though, are two really important things that also ensure that this happens in an effective and evidence-based way, and that's having organizational policies that support harm reduction and organizational policies around substance use that do not contradict harm reduction. In our research, we found sometimes that there might be a philosophy or a policy of harm reduction, but it's contradicted by a housing policy that prohibits use on site. And so substance use policies should be aligned. And then critically underlying all of this and the way that it's done is the role of drug user participation. I know in many places here, oftentimes people with lived experience or experiential workers, they're identifying people who would benefit from safe supply. They're working in collaboration with the team. This has particularly been happening in some of our new settings, our hotels, and they're a really important part of the team. Then Sharon was right. I can't not talk about managed alcohol. and our Canadian Managed Alcohol Program study, and some of the interventions, that some of the evidence related to that particular intervention. And I think it's important because it complements, you know, the evidence that Sharon laid out in her really well described evidence base for some of the other medications. And so here's kind of a list of the evidence related to managed alcohol programs. And we have been researching these programs for almost 9 years. That's when we put in, I think our first proposal was approximately 2011. And we've done this in collaboration with about 10 different managed alcohol programs across the country. We're now working with colleagues in Scotland and Australia to expand the evidence. And I've just highlighted a few things here from the Canadian Managed Alcohol Program study. The first one comes from a paper that we actually released. We have 2010, but it's actually 2019. Sorry about that. That really highlight how MAPs disrupt the cycle of displacement and survival, and they help people to stabilize and provide opportunities for connection to self, connection to family, connection to friends, in a way that's really consistent with a path to a journey of recovery and a path for healing. A lot of our quant data has highlighted that safer sources, so people are using, you know, they're binge drinking less. They're also not drinking illicit alcohol like rubbing alcohol, so that, you know, we're seeing people transition to safer sources, but also safer patterns of consumption, you know, a smoothing of the pattern, and actually overall lower consumption as well. So even though people may drink daily or close to daily, they actually consume less than people who are not on MAP. And then obviously drinking in a much safer setting, so people are much less risk for things like violence and assault. They have significantly fewer self-reported acute and social harms. And we're just analyzing our data now around chronic harms. And in fact, we're going to release that in June. So be prepared for some new insights into the long-term impacts as well. And people are more likely to retain their housing. They experience much higher levels of quality of life and safety. And then we've done some initial economic costing, reduced hospital savings, time in police custody as well. And particularly, I want to point to the last one, is they're less likely to budget for essentials, drink non-beverage, steal, commit crimes, go to treatment. And also, and I realized it's probably was the most important one to this talk, is people are less likely to use illicit drugs if they are in a managed alcohol program. And we've had a number of examples of where during COVID, where alcohol hasn't been available to someone, and they've substituted an illicit drug, and it might be something that they haven't used for a while, and experienced an overdose. So MAPs are also protected in that way. So I'll turn it back over to who's ever next.
Great, thanks, Bernie. So we're going to move now into our discussion period with Patrick and Guy. But before we dive into our juicy questions here, Guy, did you want to make any opening remarks just about the experience of homelessness?
Yeah, sure. Thanks for having me, everybody, today. I'll give you a glimpse in from my own struggles with being homeless and the struggle that comes with it. The first time being homeless was at the age of 12, where I ran away from enduring verbal and physical abuse. I slept in a tent at my friend's family's backyard, and for the first time in my life, I felt the taste of isolation and loneliness. I was picked up by the police and, of course, brought back home. And sadly for me, I kept running away until finally being incarcerated in a juvenile detention center, which was a much safer place for me. I spent 25 years being homeless, 20 as an adult, 5 as a youth. I'd also struggled with substances for 3 decades. I have recovered from substances, but still suffer the punishment from physically being homeless all those years. And sometimes I do suffer emotionally witnessing others who are struggling today. Being homeless, I felt the shame and how I was treated by society, the long glancing looks, the comments, loser, get a job, you can't use the washroom, you stink. I've heard them all. Imagine having no safe place to live and what goes through your mind. It brought on anxiety, depression, self-hatred, but mostly sadness because I was suffering. I would sleep in doorways, underground parking lots, only to be woken up and told to get lost. I've been arrested for trespassing. I was made to look like a criminal for being homeless. I finally just gave up and started staying up all night because it was so challenging to find a safe place to sleep. I didn't have the ability to focus on anything else being homeless, and it was now starting to impact me mentally and physically. My body was worse, my feet were swollen, my back was hunched, my overall health was deteriorating. I started getting infections. I stayed in many places and even in the Woodward squat. However, I didn't receive housing. My consolation prize was welfare to survive on $165 a month. I was given barely enough to survive. Homelessness is the most punishing thing that I've ever battled with, looking back on all my struggles. I'm saddened that people in Canada don't have access to safe housing. It's not a complex issue, it's a solvable issue. By implementing sustainable housing to everyone across the country, and what COVID-19 has done is exposed the lack of action in regards to housing people. All I've known my whole life is how to fight and survive, and I will continue to fight for the right for housing for all. Thanks for listening.
Wow, Guy. Powerful remarks there, and such an inspiration to all of us at the BCCSU, those on the line, and just a shining reminder of how important it is to connect folks to options and treatment and just do better as a province. So thank you so much for sharing. So I think this is a nice place now to move into some of these questions. And Patrick, we're really lucky to have you given all your experience on the front line, and thanks for all the work that you're doing. So from a frontline's perspective, how has the effect of illicit drugs changed in the downtown east side?
Yeah, thank you all for having me. I really definitely appreciate it. And it's been really interesting, hearing, I guess, the testimony from, the previous speakers as well as Guy's testimony. That's powerful. Also a huge motivator. It's very interesting kind of hearing these things going back and forth when, for example, Dr. Bernie mentioned, the at-home study. For example, that was one of my first sites that I worked at, was the Bosman here in Vancouver, which was a huge part of that. So, I guess piggybacking onto my learnings from like managed alcohol programs were huge. When I first started, this is back in like 2011, 2012 area, you would see kind of a lot of rubbing alcohol bottles just kind of on the street and things like that. And you would see kind of the adverse effects it would have on people's lives, not only like the physical, jaundice, kind of sunken cheeks and all of that, but also the behavioral. You would see how quickly people could go kind of downhill with their health outcomes and things like that. And then you see, through different other programs, the managed alcohol program. So there was like kind of in a clinical setting where people would be getting that alcohol, over a certain amount of time, to drinkers lounge program, which is absolutely phenomenal. It's actually there today. Insofar as that, and you see such improvement in people's lives, such stabilization, because whether it's people getting the DTs or all of the other things, the withdrawal from alcohol can be so bad, and that inspires so many other behaviors, right? To be in withdrawal from any illicit drug is a terrible thing to witness, let alone to experience. So that being said, with the implementation of these programs, they do two things. One is they have an incredible effect on an individual's health, and that's holistic. So from, their spiritual, mental, emotional, physical health, and also as a wonderful externality, it creates a sense of community, specifically with alcohol. It's such a social drug for people to use. They use it together and they lean on each other, and, add housing to that. Then you have a routine and almost a community-based care plan where, you know, if you consume too much or, you know, it's used in conjunction with other substances, then it's very simple to take somebody home and to let front desk staff know, for example, hey, go check in on so-and-so. You know, we're putting them to bed essentially, which is such a wonderful and humane and dignified intervention at that point. In addition to, like, the fentanyl crisis is still so very real. And that's in any community that, you know, I'm lucky enough to work in. I remember one of my first shifts, I was working at the Newfoundland shelter many years ago, and fentanyl was kind of a thing. When I first started, it was, you know, we had the intranasal naloxone, and that was a piece of training, but it wasn't something that was very often used. And when it first found its way into the neighborhood, like, wow, we were doing 4, 5, 6 overdose reversals a night. In those days, you would literally be able to track a bag when it came into the building, people having no resistance, no acclimatization to how strong this was. And then from there, so many loved ones just started dying, so many people. So that being said, it's, you know, there's so many interventions that have gotten so much better, and the stigma has come off it to a certain degree as, you know, the drug users themselves become more sophisticated in their use of the drugs, using the overdose prevention side, things like that. But also too, it's been a lot worse because the grief, everybody knows, everybody's been affected by this. So that's why this is such an exciting and unprecedented time, bringing in that safer supply, because people now have an opportunity to conduct their pain management in a much more stable way, I feel.
Thank you. And so what's the difference in your mind then between illicit drugs and being able to have prescribed options?
Yeah, that's a really good, question. Basically, in my mind, it kind of boils down to, you go from being somebody with an addiction to somebody with a prescription. So for getting people, that was one of the programs, one of the interventions we were able to run as we were doing outreach into, say, most recently the Oppenheimer encampment, right? So we would be discussing with people and discussing, you know, what they use and how they use it and why they use it, sometimes when that's divulged. And it was just such a wonderful thing to be able to bring people into an office and have a frank conversation about what they use and what that means to them. And then from there, get them in front of a doctor. You know, now that you know, at least I'm very lucky working here in the downtown east side. There's so much talent down here from a medical perspective, and so much compassion to have a frank conversation, being like, okay, you use, you know, how many points of, say, down a day or opiates a day? Okay, cool. Well, that relates to this much hydromorph or Dilaudid or whatever that, you know, whatever that prescription happens. And there's something so special that happens in that context, where it's so dignified and it's so respectful and it's so helping and caring, that people really feel supported in a way that's very real to them. You know, we all go through what we go through in our lives, but down here, from my experience, an individual's day is really predicated on what it takes to not be sick, you know, and what it takes to manage that pain for whatever reason they're going through. So that being said, the difference between the illicit drugs, which can kill you, you know, a piece of fentanyl particles in a bag, you know, the supply is so poisoned that everybody knows how dangerous it is. Really, they're playing Russian roulette every time that they use, and their body physically needs that. To being able to have a stable supply, to be able to time it, to build a routine around it, you know, is such an empowering development in the way that we apply our care.
Mm-hmm. And as someone who's working directly in the Oppenheimer encampment, what has been the effect from your perspective? What are you seeing in terms of those folks having access to safer supply?
It was amazing. It was absolutely amazing. I've been lucky enough to do a wide range of work on the front lines, and I haven't seen anything like this at all, ever, really. It was, you know, we had been there for months at that point. We, you know, We've cleaned, we've laughed, we've cried, we've pet puppies, we've done favors, we've had favors done for us. You know, luckily enough, we were a part of that community, I feel. And to be able to have a frank conversation with somebody that you consider a friend, and to be like, hey, by the way, we have this amazing opportunity for you. It takes about an hour, front to back. I just need you to come with me, you know, ask some, you know, pre-qualifying questions, nothing major, just being like, who are you connected to health-wise? You know, come by, do a urine drug screen, and then from there to get them FaceTime to a doctor. Like, just that level of access alone is amazing. And then from there, okay, have a very frank and open conversation. And it was really surprising me, actually, how willing people were to tell their stories in that context. They felt really supported and really, really compassionately cared for in my experience, which was phenomenal. And then from there, okay, that's done. Go buy your pharmacy of choice in 20 minutes or an hour, and they'll have your prescription ready for you. And then from there, oftentimes we would just have a juice box, hang out, and then literally walk people down to the pharmacy so that they can pick up the first prescription of, especially for the stimulant users, you know, Dexedrine or Ritalin or whatever it is. And from there, when they hold that prescription in their hand, they're like, oh, and you can see immediately how much bandwidth individuals got from that kind of intervention, being like, oh, now I don't have to worry about this, you know, this bicycle that I have to fix and then find a buyer for. And then from there, go to, you know, whatever drug dealer, supplier, you know, they have, and then whatever risk is involved in that kind of a situation. And then from there, find a safe place or a safe space to use that. And then the whole time, you're risking your life. One of the things that was surprising, but not really surprising, was even individuals that we were, when we were doing urine drug screens, that were like, oh, no, I've never touched an opiate in my life. They were coming back positive for fentanyl because it's literally in everything. So once an individual was kind of on this routine, you know, picking it up week after week after week, especially the stimulant users, like, oh, I haven't touched methamphetamines in a couple of weeks now. You know, this amount of Dexedrine is really, really working for me. And it's a lot easier on my body after that. They're like, I don't feel such incredible withdrawal. And just to know that I have it on me gives me a lot of, I guess, more psychic bandwidth at that point. So it's just been such a phenomenal intervention. You know, working down here for so long, that's something that you hope and pray for, you know, at 4 a.m. in your most secret moments. But to be able to see it for real happening to people you care about has been something absolutely game-changing, to be honest.
Thank you, Patrick. Can't thank you enough for all the work you're doing on the front lines, and certainly the work that you're leading in Oppenheimer Park is just extraordinary. So just a huge thank you to all your work. So
thank you.
Yeah, with that, we're going to move over to Guy. Guy, we have a couple questions for you as well. So how does being homeless impact your overall health?
Well, I mean, it's relentless. It's just immense punishment. I mean, you know, the complications that come with sleeping on concrete or cardboard for many years are just, you know, your body, your bones, it's just arthritis, hard to repair, you know, just to even, you know, think about getting out of that and then tackle on all the other issues. And then, you know, you're dealing with, you know, arthritis and constant pain from being homeless. You know, the only thing you got is really to use substances to try to absorb some of that pain. It's just, you know, a lot of the times, even my osteomyelitis that I'd had, you know, 5 times, it was all brought on from a combination of things. But, you know, when you don't sleep, your body doesn't repair itself. It wears you down. Not only that, it wears down your mind and then breaks you spiritually. You know, and oftentimes, especially when it's, you know, in Vancouver, where people think the weather's nice, let me tell you this, you try sleeping outside in the winter. It's freaking cold, it's bone chilling, and it's relentless, and it just doesn't let up. And so, you know, especially now, impacting people's health immensely. I mean, just until the last couple of weeks, I mean, with all the places being shut down and closed and you couldn't go inside, I mean, you know, people were, you know, struggling on top of their struggles. But yeah, you know, you just don't, your body just doesn't repair itself, and then you get sick, and it's just mentally, physically, and spiritually crushing. I think it's one of the things that I really reflect back on, and you know, every time I take a step or I walk, or after a while from standing, my back reminds me of, you know, years of just the punishment of being homeless. And it's like, yeah, you know, and I can only imagine what the people are going through today. So it's you know, unbelievable.
Mm-hmm. Guy, when you were homeless, safer supply wasn't an option for you. So can you speak to the challenges specifically around the grind for trying to access the illicit supply and the risks that you put yourself in?
Yeah, I mean, you know, you're battling, you know, a substance use disorder, an opioid use disorder, and that and is just an immense challenge in itself as well, because you know your day, your life revolves around, you know, getting to use to not be sick constantly, and that in itself too is trying to escape all the other issues, social issues that you're dealing with. You know, having that on top of everything is just you know, a recipe for death. And you know, it's great to see people having the ability today, and it's unfortunate that you know, we're trying to play catch up with the guidelines. You know, I envision it as you know, if this was a true version of safer supply, that it would be implemented for everybody that needed it or at risk for an overdose. And that's the way it needs to get to. I'm optimistic. I'm always hopeful, because without hope, you know, we really don't have much. So, but for me, when I had to access the illicit drug supply, you know, obviously, luckily for me, that I was brought back to life, you know, 6 times. That you know, a few of them had to be at the supervised consumption sites, but I was lucky a couple of times as well that just people were around, and overdose weren't that frequent at the time that I was overdosing. So you know, you look back and you wonder how you get through things, or how you get out, and you're just grateful that you know, that you had to live, and you fought another day. And really, that's what the battle is for people that don't get access to safe supply, is that battle. And people are battling just to live, never mind living. You know, there's that battle just to live for the day, and that's just immensely challenging for the people that are struggling today.
Mm-hmm. And can you speak to whether shelters are safe or not?
Yeah, so you know, shelters are, you know, they, first of all, they give the illusion that people are being housed, but a shelter isn't a home, for number one. And whatever rules that are in the shelters, the street polices itself. So you could put anything you want, or any rule or regulation in a shelter, but it's the people of the street, because that's what you fall under. And that's what a lot of people don't understand, is that even though a shelter is an option for people to go in, you know, for a lot of the times, a lot of people are enclosed. They're now, if they owe drug debts, or you know, especially I've known many females that would just sleep anywhere else but a shelter, just because of fear of being taken advantage of, lose their drugs, getting robbed, their stuff stolen. Are they safe? I mean, I guess when you're in there, but still, when you leave at 6 in the morning, and you walk out onto the street, if somebody's looking for you, they'll wait outside that shelter for you, and then the shelter won't do anything and won't be able to do anything. And so it's really this fine line of like safety. And I think, you know, shelters aren't they're just not any, you know, answer to the solution. I think the solution is getting people housing. And as you can just look at people that sleep in tents at parks. And even when I was at the Woodward squat many years ago, you know, I felt more comfortable there than I did at any shelter. And so, those are the challenges that are in place. And plus too, repairing the fractured relationships with, community service providers, health authorities, and all that is there's a long history of trauma that's been impacted. And so, still people are leery, and especially, you get somebody that, unfortunately, it just takes one time for somebody to go through a bad experience somewhere that impacts them, or their past trauma, how, new trauma, it relives old trauma. So there's just this reliving of the trauma that people are going through. And so that becomes a safety issue and a safety concern. So a lot of people feel more comfortable sleeping in parked cars and underground parking lots and or doorways, just because they have that freedom to be able to move or to leave, or something goes wrong, that they feel more comfortable. So yeah, they're not going to protect somebody, especially when you leave.
Thanks, Guy. So now we're going to use the last 10 minutes of our discussion here to take questions from the chat function. So I'm going to start, and Sharon, this question would be directed at you, but can you speak to how pandemic prescribing works for people who have both opiate and stimulant use disorders? Oh, Sharon, you might be on mute.
Yes, I was. So I don't know how much confidence that instills when I can't unmute myself, but here we are. So the question is, how do we approach pandemic prescribing if you have an individual in front of you who has both an opioid use disorder and a stimulant use disorder? And so, that combination is actually easier than perhaps some of the other combinations, in that you would approach the opioid use disorder. I would suggest looking just at how you would manage opioid use disorder. So in a lot of these cases, this is, trying to optimize perhaps the opiate agonist therapy agent that they're on, and then providing additional PRN access to either the hydromorphone or the MS-LON, depending on the patient, depending on the needs identified, depending on the location, et cetera, et cetera. And then looking at the stimulant use disorder and making an assessment as to which of the prescribed stimulants would be appropriate. And it is, it's something you can do with a degree of confidence, in that the stimulants should not be putting the individuals at higher risk of negative outcomes, in that they don't act in concert or concomitantly to increase the risk of overdose. So what I'm getting at here is, opioids plus stimulants are something that you can do with a bit of a buffer, a safety, a feeling of safety. The difficult question actually is, what do you do with someone who has an opioid use disorder and a concomitant benzodiazepine use disorder? How are you going to approach prescribing two substances that can act together to make that risk even higher? And so that is the tougher question that we face. But stimulants and opioids, you can basically just run your finger down the line for how to prescribe opioids in the setting of the pandemic, and then run your finger down how to prescribe stimulants, and it's okay to combine the two.
Thanks, Sharon. Question for you, Patrick. At the encampment, are doctors or prescribers coming to the encampment, or are you taking folks to clinical offices?
Yeah, so in that context, because there's a lot of confidentiality issues, we would take them off-site. And then from there, we would just kind of use a clinical office. And then from there, either they would sit with the nurse would build their EMR at that point. And then from there, then they would FaceTime or telehealth with a physician.
Great. Bernie, perhaps you can speak to this point a little bit, but do you have any recommendations for folks in more rural areas and how any strategies that they can implement to help when they have lesser resources than somewhere like Vancouver?
Yeah, that's a great question, because I think harm reduction in general, there's often not the services available or the expertise available. I think if we're talking in the province of BC, there's excellent kind of, I would say, resourcing in a way for all areas of the province through towards the heart, and establishing, a harm reduction kind of site. But I'm going to go specific for a moment to, prescribers. And I think it's finding those prescribers, or helping to facilitate people to be a prescriber who is someone who is open to safe supply. And also, I would say in BC specifically, we've got a lot of physicians who are actually also very interested in MAP, even though we don't need physicians to do MAP, because alcohol is not a prescription, right? It's not a restricted healthcare activity. And so there's a lot of resources on www.cmaps.ca about how do you set up a MAP. So those are some thoughts. And I realize people in rural areas are stretched very thin. So, you're often doing many things, but I think those are some places to begin to look for support and help.
Thank you. Sharon, safer supply, pandemic prescribing, what's the difference? Which terms do we use?
Oh, Amanda knows I like this soapbox. So, safer supply is actually probably a perfectly acceptable term, in that it's very gray and probably a little bit difficult to pin down. I think the term that some of us struggle with is the term safe supply. And this has been hit upon by a few of the speakers already, and that safe supply is really something to do with the criminal justice system. It really has something to do with policy and the legalities around accessing substances. It is very difficult to put safe supply within the context of a prescribing algorithm, because what happens is if you put the access point behind essentially the set of rules that physicians and nurse practitioners have to adhere to in order to align with our licenses and our college requirements, it's quite a barriered approach. And it actually puts some of us in a bit of a funny situation or position, in that, as a citizen, I full out 100% believe in safe supply. As a physician, it's a little bit more difficult for me to provide supply in the way that I think safe supply should be provided, in that individual gets to make a well-informed decision and makes the decision to use supplies, whatever substances they would like to access, and be guaranteed that the supply is safe. So as a physician, I have to take on the responsibility of the potential risks associated. And so I really look at this guidance document as Amanda said, as risk mitigation, really looking at case by case. Where does the risk lie? Where does the benefit lie? What is the surrounding milieu, or what is the surrounding environment? So the decision I make for an individual who's marginally housed and now finds themselves in a position of having to isolate, either swab pending or due to being COVID positive, is very different than perhaps the decision I make for an individual who is fully housed and is doing well on their opiate agonist therapy treatment, and has certain requests that potentially align with the pandemic prescribing. So as soon as you put it in a prescriber's hands, there is an element of risk-benefit analysis that we have to do. Right now, today, in the context of a pandemic, these decisions are a lot easier to make in terms of prescribing and providing access, then perhaps they will be a year from now when, you know, here's hoping the pandemic's a distant memory. So yeah, thanks for that question.
All right, thank you. And then we had a couple other questions in the chat, but we won't have time to address those. So we will try to pull those out and create a bit of an FAQ or get back to you directly with some of those. But with that, here are a few resources that you could link to if you're looking for more information, particularly that first bullet as it relates to vulnerable populations. But with that, we've hit 1 o'clock, and I just want to thank everyone so much for attending. A huge thank you to our panelists. I thought this was great discussion today, and really looking forward to carrying these conversations through our work and over to you folks who are tuning in that work on the front lines and supporting people who are homeless. A huge thank you to all the work that you're doing and for the province. With that, we're going to say thank you and goodbye, but thanks for being there with us today. Bye, everyone.
Thanks, everybody.